with the Destiny Breast 12, they looked at patients with the active brain mets. Talk to me a little bit more about the study, a little bit about the design, what phase what the study was, and a little bit about the results.
So let's say this was Destiny Breast 12, a phase 3-4 trial. It was after approval to try to expand the data we have in certain important populations of patients. And so it included about 250 patients with HER2-positive metastatic breast cancer and brain metastases, including both those that we consider stable, meaning that they have been pre-treated with radiation treatment or surgery or something else, and they're not active, or instead active progressing, brain metastases that either were just diagnosed or that previously treated but progressed. And so that population of active brain mets, we're talking of a very important unmet need. All of them are unmet needs, but like inactive brain mets, they're usually excluded from the trials. Instead, here they are enriched. And then we have also 250 patients without brain mets to kind of try to understand with or without this important feature of brain mets, what is the efficacy of T-DXd. And basically, I think that the big takeaway message is that T-DXd works amazingly in HER2-positive metastatic breast cancer inside and outside of the brain, like both in the body metastases and in the intra-CNS metastases. We saw about 70% objective response rate and intracranial response rate in these patients, which was remarkable. The PFS and intracranial PFS were beyond 1 year, were up to 17 months.
Fantastic.
And it was very interesting to see that the overall survival in the cohort of patients with or without brain metastasis was basically the same.
Yes.
Was like the curves were the same.
Yes.
Basically showing that if you use a highly potent drug that works inside and outside of the brain, you can basically revert the adverse prognostic effect of brain metastases. Of course, these are the first presentation of the data. We need to follow this data to see how it evolves. But I think like it's striking and really kind of closed, let's say, this question of what should we use in second line for patients with HER2-positive metastatic breast cancer.
So that's the question. That's the question. For me, that was enough. That was the data I wanted to solidify that regardless of brain mass or no brain mass, T-DXd is my second line. My third line will be the HER2-CLIMB regimen. How about you? Do you still see that there is a space of doing the TTC regimen before doing T-DXd, or for you also that solidified T-DXd as your second line choice?
I personally don't. If you think of it, we have T-DXd with 70% intracranial response rate, a PFS that exceeds 1 year, studying a large population of patients, and it's 1 injection every 3 weeks. And on the other side, you have 3 drugs, an injection plus 2 oral drugs that have got a median PFS of 8 months and a response rate of 40% intracranial. So I think T-DXd is just like, we shouldn't do this, but we do it for the benefit of patients to compare trials. And they're not identical.
Nope.
The TTC regimen was a randomized trial that tested this hypothesis, but with T-DXd, we got so much data now telling us that it works in the brain that I think for the wide majority of the patient, if not all, T-DXd is my second line choice, irrespective of brain metastasis. Probably the main category of patients where I may have concerns is those with lung comorbidities, because one thing that was observed in the Destiny Breast 12 is that the rate of ILD was a little higher compared to Destiny Breast 03. And also there were several fatal cases of ILD, about 2%, basically telling us that this population of patients with brain mets is probably a more vulnerable population. They are under steroids to reduce the edema. And so it's important to remember that some of these patients may be at risk for ILD, and probably I may use something different first. But we're talking of a minority. The wide majority, I think, second line T-DXd emerges as really reinforced as a treatment in the algorithm.